So when we are assessing chest pain, like I said, we're gonna do that assessment. Where is it? Is it radiating? What other symptoms do you have with it? Because you will need to know the difference between stable and unstable angina. So when someone has repeated chest pain, usually they're put on nitroglycerin. So that's a little bottle, that dark bottle that you see on there. There's tablets in there, and we give patients specific instructions on how to take nitroglycerin. So when they have chest pain, they can take one tablet. This is them at home, not us in the clinical setting. But they take one tablet, wait 5 minutes. If they still have chest pain, they can take another one. But us in the clinical setting, we know the side effects of nitroglycerin. We know it's going to lower our blood pressure. So before we give any kind of nitroglycerin for chest pain, we want to make sure we're checking the blood pressure and pulse before we do it. Because if it's under 90 systolically, there's specific order, we won't give nitroglycerin. We're going to have to figure something else out for this pain, for chest pain. So we're going to check blood pressure, pulse. If they're having chest pain, give it. And then we wait 5 minutes. And we're sitting with them at the bedside, like, waiting, how's your chest pain? Is it getting any better? Because we want the patient that's having a heart attack to have no pain. We want that pain gone, because any kind of pain in the chest or in the heart means that, or pressure, that's another thing. They say that they have chest pressure. That means that the heart is not getting enough oxygen. So we want to make sure we get rid of that pain or pressure. So we give them nitroglycerin, and we're sitting at the bedside, we're waiting there. We're sitting with the patient. How are you doing? Then after 5 minutes, we take that blood pressure again. If they still have pain, we give them another nitroglycerin. And we're there for 5 more minutes with that patient. And then if they still have pain after 5 minutes, again, we take their blood pressure, pulse again. If it's stable, we give them another nitroglycerin.
Can you give it before the complaint of chest pain?
You can't give it. If someone has history of chest pain and they know they're going to have chest pain, yes, you can give it. Like if, say their job is really stressful and they know they're going to have chest pain, or when they exercise, or when they do something strenuous, they can take a nitroglycerin before they do it. Where was I? Oh, nitroglycerin, because it is a vasodilator, the side effect of that is a severe headache. So usually Tylenol is ordered in addition to help treat that headache. But nitroglycerin comes in the tablets. That's what we see mostly. A topical, maybe the nitroglycerin tablets are not working, so there is a nitroglycerin paste. I call it a parchment paper with a ruler on it, and you just squeeze a little bit of the paste on the parchment paper, and it's just literally give an inch of the paste, and we just slap that on and take it on to their chest. The other route is IV. If their pain is still not being relieved, we could start an IV drip for nitroglycerin. So it just really depends on their pain, but we want that pain to be like not at all, completely even, no pain at all, no chest pressure. But we have to look at that blood pressure. Safe education with nitroglycerin. Make sure that they have a moist mouth. Make sure it's not dry. We might be able to give them sips of water beforehand, because we're putting it under their tongue and letting it dissolve. We don't want them to chew it up. We want them to put it under their tongue, let it dissolve. Sometimes it's tingly. That means it's just working. They have to renew their supply every 6 months. So after 6 months they've had it, they have to get new tablets. Like you said, they can take it when they're anticipating pain, and know how long it takes for pain to be relieved. So maybe they take it, but 1 or 2 minutes, it takes 1 or 2 minutes for the pain to be relieved. So this is good information for us to know and the doctors to know about the pain medicine or the nitroglycerin. As I said, severe headache, flushing, have them sit down or lay down when they're doing it. Why would we want them to do that? If they pass out, they're already on the ground. But yeah, have them, if they're feeling dizzy, have them sit down, make sure we keep them safe. Like that little bugger there, he's falling backwards. So, we have chest pain, then another, further step to this is an MI, acute coronary syndrome. Usually it's somebody with unstable angina. Remember, there's stable and unstable. So this is a person that has chest pain that's lasting more than 15 minutes. There's plaque in the coronary arteries that's either blocking the artery or actually ruptures the artery. You can see a couple of pictures there of where it looks like, what it looks like. So with a MI, myocardial infarction, there's a difference between a STEMI and non-STEMI. A STEMI means that there's ST elevation on the EKG, and I have a picture of that in a little bit. That means that their whole heart wall is damaged. And they'll have usually life-threatening, so your VFib or VTAC. Blood flow to the heart is compromised, the oxygen is compromised. All those words just mean lack of oxygen to the heart. And like I said, unstable angina, pain lasting more than 15 minutes. It's either stable or non-STEMI or STEMI. And I already talked about the female, they might have different symptoms than the males. So here's the difference between the non-STEMI and STEMI. So you could do a stress test, but that's okay. We're going to do that with everybody. But the MI classifications. So see how this ST elevation, where is it? ST, see how this doesn't always go down? This is normal. The ST elevation, this line doesn't go all the way down to the isometric line. It stays elevated. So that is an ST elevation MI. And you need to see these in 2 different leads. So see how this is elevated right there. It doesn't come all the way down to here. It's right there. So you need to see this in 2 leads on an EKG, not just one. So if you have MI alerts at the hospital or wherever you work, that means like either in their emergency room or if they're coming in by squad, that they see those 2 ST elevations. They can transmit send a copy of the EKGs to the hospital now. But so that's why we do those MI alerts. But like I said, 2 elevations or 2 ST elevations and 2 leads is ST elevation. Non-ST elevation, get it? Non-ST elevated MI. There we go. The ST elevation is not there. It's either depressed or it's even. It's still an MI. It's still a heart attack. It's just meaning a heart attack that doesn't have an ST elevation. Is it less worse than? It's a little less. It's less worse. That's why they wait till Monday to do it. Don't say this in public that I said this. But here's the difference. So see that top picture? This is that non-STEMI. The ST is depressed, but only a partial of that cardiac wall is necrotic. Where ST elevation here, that whole heart muscle is necrotic, and that's the difference. So yes, it's less severe because not the whole side of that heart muscle is necrotic, where ST elevation it is. So you can see here's an EKG and leads V1, 2, and 3, I think. You can see the ST elevation. You can see it here too. but they're looking at
Oh,
all
I see
these.
it.
And this
I see it.
also, let me look. When you're looking at the 12-meter EKG, this is what the doctors are looking at. Because if they see that, what was it, leads 1, 2, and 3, so every direction that this lead is looking at the heart, there's necrotic tissue, that ST elevation is there. So that's what it means, it's looking at the heart, they're saying, okay, there's no electrical signal there, so that's why there's ST elevation. And then they can pick out which coronary artery it is. So if they had the left anterior descending artery, that's the widowmaker here. Because this one carries a lot of, if you see a heart cath, go in and look at it. Because you can see the blood supply here. So they know that it's in leads 1 through 4, that this is the part of the heart that it's looking at. And the circumflex artery, that goes to the back. And that's the leads, they can look at that part of the heart. So when the doctors are looking at that EKG, they can see what part of the heart is affected. So in an emergent situation, they can go in and say, okay, I know it's on the right side. So they can hit the right artery first, or the right coronary artery first before the left. So what cardiac enzymes are we looking at? For our troponins and what else? Yeah, our CKD, I don't even think it's on here. No, but you're right. So here's another one where there's another EKG, where you can see the leads are in lead 2, 3 over here. Not in lead
CKMB.
1. We'll press lead 1. Oh, that's lead 1 is right. But yeah, you can definitely see the difference when there's an ST elevation.
Did you say the widowmaker was the LED?
The left circumference, yeah. That's just nice to know. Because it supplies so much blood to the heart. What you will need to know, you'll want to know Mona. She's gonna immediate treatment for an MI. Morphine, usually we're given 1 to 10 milligrams IV push of morphine. Oxygen, 2 to 6 liters. Nitroglycerin is the tabs. We're gonna give those nitroglycerins every 5 minutes. 3 max, no more than 3 after that. After nitroglycerin, I didn't say that. After you give 3, you can't give any more. You gotta do something else. Do the paste or do an IV drip. And then aspirin. And usually, the reason why I have 324, 325 is maybe they have baby aspirin, so that's 324. So you have them, Mona, morphine, oxygen, nitro, and aspirin. It depends. You can. If it says chewable, like the 81, you can, but I'm trying to think. If it's 325s, you don't. So it just really depends. You gotta stay specific to the doctor's orders on that. Other interventions, beta blockers, because that decreases the oxygen demand, and if they have any dysrhythmias associated with that. And I'm starting to see more heparin boluses and drips coming before they, if someone's coming in with like a ST elevation MI, they'll get heparin like 3,000 bolus or that in the emergency room before they come to the cardiac cath, just because we want to decrease any clotting factors. That's becoming more the norm practice right now. So when we have a cardiac cath, there's 2 locations that they go in. They can go up the radial artery or the groin. And they're feeding the catheter up to the heart. They're releasing contrast dye because they want to go in and see the blockages. They can either put a stent in to open up that blockage. They can remove the plaque and do the balloon inflation. So here's another picture where they just go up through the groin, or they can do the artery. This is usually doctor preference. Depends on the patient also, but it's doctor preference right now. Right now it is. Some doctors like the artery, some, the radial artery, some don't. So here's a picture here on the right, you can see that, that obviously the heart's not getting, very perfused. On the right, you could say there's a little more perfusion, but I think there's arrows where you could see some stenosises. Oh, I don't see them. Maybe it's the next slide. I think it is. So here you can see, as you can see, the difference between the left, on this side, there's more perfusion, on this one, there's not much. But you can see where those arrows, you can see the narrowing of it. I remember when I was in school here, I went to the cardiac cath and I went to see, was with the doctor, and he was really good and he was showing me afterwards what to look for. And I'm like, oh, that looks good. He goes, no, this is what it should look like. I'm like, oh, that looks bad. So, but that's when they're going, and like I said, if you get to go see it, it's really kind of cool to see. Not kind of, it is. So pre-procedure for cardiac cath, we are getting informed consent. We're keeping them NPO. We're doing vital signs. We're checking those peripheral pulses and putting X's on their peripheral pulses. Because when they're in the cath lab doing this, they don't want to spend time looking for those peripheral pulses. And you know the anatomy is not the same for everybody. So the less time that they have time to look for those pulses, the better. Assess their allergy to shellfish, contrast dye, because they're going to be using contrast dye during this procedure. Check their renal function. We're looking at their BUN and creatinine, because the contrast dye does interfere with renal function. And just check blood work. Look their PT, PTT, hemoglobin, whatever it is. During the procedure, nurses are administering sedatives. We're monitoring their chest pain, vital signs, and heart rhythm. Usually there's nurses that are with the patient in the cath lab and with the doctor that are helping with the procedure, but there's another one that's in another room with the monitors, charting everything, but they're like looking at the rhythm, they're looking at the blood pressure, they're the ones, well, they're all monitoring, but usually the one that's sitting outside the room is monitoring everyone, because sometimes the people in the room are so focused on what they're doing that you need that extra person out there saying, hey, blood pressure's dropping, hey, their heart rate's 30.
What if they do have an allergy to shellfish? Is there like
You
an
can give
alternative?
Benadryl, they can give Mucomyst. They do give medications prior to the procedure, because this is more like, this is life threatening, they need to do that. So there are medications that you can do to do that. And be prepared, there's a crash cart right in the room that's right there by the bedside. So just be prepared. Post-procedure, monitor vital signs. Every 15 minutes, we're looking at the fetal pulses, because before wherever the procedure took place, say it was a radial pulse. We want to monitor those neurovascular checks in our fingers, because we want to make sure a blood clot's not forming. So we want to make sure that we still have good blood flow to our extremities. So we're checking those. Bed rest. Nowadays, it's different. There's different orders. There's different types of closing the sites. But usually they're on bed rest 2 to 4 hours. We want them flat. We don't want them bending at the waist or putting pressure on the groin. Pain management. Monitor urine output. Are they starting to have heart failure or something because of that? Monitor any tubes or equipment. Apply pressure, yes.
So when they get to the ER,
I know, it's a life, yeah. Yeah. So we're just, I know, but it's heparin, that's a quick, fast acting one. It's only, half-life is a lot less than like Lovenox or something like that. But, and they're only getting, usually the bolus is about 3,000 units or 4,000. I haven't seen anything over like 5,000 units. 5,000 units is what is given sub-Q every 8 hours, so your half-life is 4 hours. But they have a clot in there, so we need to dissolve that clot. And giving heparin is kind of a life-saving medication. Right, and within the last, well, it's been in your books for a while, but now I'm starting to see it more, for the last 2 to 3 years now. I'm seeing heparin and boluses given more before they come back to cardiac cath lab.
Can you still see the sensor, like with the TR band that they put on? So it's like.
Yeah, the TR
You can look at it.
Yeah, the TR bands is what is, if it's done at the wrist, at the radial artery, is how they close it. It's called a TR band, and it's clear. So you can see, and it's covering the insert right above the insertion site, because we want to put pressure on that artery. As you can imagine, you gotta have pressure on it for a long time. But yeah, those TR bands are clear, so you can look at the site. And you decrease, that's too much to know for you guys, you don't need to know all of that. But you're monitoring that site. If there's just a regular dressing, you don't ever wanna pull that dressing off and put a new dressing on. You just wanna put new dressing on, because what if, a blood clot has developed at the end of it, but it's still a little oozing? If you take that dressing off, now you're taking that blood clot with it, and so now you need to apply more pressure again. So if there's ever drainage on your dressing, you just apply more pressure, put more dressing on it. You don't take off what was there and put something new on. Yes,
After how long do you take that off? After the 4 hours?
the dressing?
Mm-hmm.
No, we don't take it off at all.
The doctor does it?
The doctor will do. Well, let's talk about the dressing in the groin or in the arm. Usually they're going home with that, because if they're just going home, we're getting too much into that. But, they can be going home. If there's no intervention, no stents, some people go outpatient cardiac cath, they come in, have it done, and then they go home. But they're on bed rests in the preoperative area for at least 6 hours before they go home. What?
With no intervention?
With no intervention if they're not being admitted. If they are being admitted, they're gonna still be on bed rest, but in a hospital room. And other dressings and stuff on there. But yeah, bed rest, 2 to 6 hours, pain management, check that dressing, make sure it's not bleeding. Hematoma, are they bleeding, but we don't see anything? Go look under that patient's back, because they're on their back. Where is blood going? It's going down. So we want to look at their back. Is there a hematoma back here? They can be bleeding a lot back here, and you just don't see it if you're just looking at the groin. So, and looking at those pulse, their feet or hands and all that. Do your safety checks. Anything else with that? Questions on cardiac cath or anything like that? Here's our neurovascular checks. We're checking for pain, checking pulses. Are they cool or are they white? Are they blue? Are they cold? Do they have pins and needles or anything like that? Here's some complications, some hematomas. You can see there's bleeding into the groin. There's specific direction or patient education post cardiac cath. Have them report bleeding, have them report any further chest pain, shortness of breath. Is there stent placement? Complications, they're in the heart with the catheter. They can do a lot of damage inside that heart. So we're still looking for any kind of persistent bleeding, bradycardias, any cardiac failures, further MI. So there's a lot of different complications that can happen post-cardiac cath. If too much damage to those arterial systems is done, then what is called an intro balloon pump is pretty much what it is. But the principles of this is this pump will do the pumping of the heart. And this type of pump, at least But this means that if a pump ever occurs, that there's multiple vessels that are blocked. They're not gonna do any stints because that's just, they're too much of an issue. They gotta do multiple vessels, for a cabbage. But a balloon pump is what actually does it inflate, there's a balloon in your heart, in the artery, the aorta, not the artery, in the aorta that deflates and inflates to actually go through the pumping action of your heart. And then when we get to a cabbage, so this is a coronary artery bypass surgery. Cabbage is the nickname, but this restores vascular blood flow to the heart. And what they're doing is this usually 3 stents or 4 stents or more. They'll do a bypass instead of doing stents. So what they're doing is they're taking an artery or a vein from another vessel, usually the leg, and they are attaching it to the aorta and just distal to the blockage. So here's the blockage, so they'll attach it to that area of the heart, because then that will restore blood flow to that area of the heart. So you can see that this vessel is sutured into the aorta, and then it's connected past that blockage right there. And it restores blood flow to the rest of the area of the heart that's being blocked. And that, when it says like a triple bypass, quadruple bypass, that's just the number of bypasses, how many vessels they use. So, education for post-cabbage, cough and deep breathe, yes.
Do they have to take those valves out of the vein to use it as an artery? The
Yeah. No, because
strip nerve or anything?
no, I don't think so. I don't know that answer. I'll have to get back to you on that one. No, I don't know that they strip the valves out, but that's a good question. So education, cough, deep breathe, leg exercises, because we gotta look at that big old wound on that leg. So when they're taking the vessel out of that leg, you have a chest wound and you also have a leg wound. So you also have to think about that you have a lot of wound care. Sometimes they'll come out with like 3 different chest tubes in there if it's pretty major. So they'll have chest tubes out of their, usually right mid-sternum here in their heart. And the kicker is the next day they're up walking. It's crazy how fast they get up walking. I know, yes.
Question. So when they take that piece out of the leg, how does that affect the leg?
Well, they do testing beforehand. Do they have other circulation through the rest of the leg? If that leg is compromised, they're not going to take a vessel from there.
Okay.
So they're going to have to make sure that there's other vessels that can
continue the flow.
that work properly before they take that.
But it can sustain without it.
Yep, it can. Yeah, so take care of everything. So all the cabbage does restores blood to that heart. If it fails to restore, you're looking at complications where that vessel can become occluded. You're looking at infection, compartment syndrome. I know you guys learned about that last semester, where there's so much swelling within the extremity that it's cutting off circulation. And the other complication is cardiogenic shock, where that vessel is so occluded, or the heart is so damaged that now the patient's going into shock because of a lack of cardiac output. Okay, that's a lot of information. All right, let's go over some questions here. All right, a 55-year-old male with a history of smoking, high cholesterol, is in the ED, crushing chest pain, grating pain to his jaw and left arm, nausea, sweating, BP, heart rate are there. Which type of MI is this guy having? Why? More than 2 leads. Okay. So 55, I think this is the same guy. Which assessment finding would be most concerning for this patient? This is a hard question. Why? Fluid in the lungs? He said fluid in the lungs, right? Or backing up.
It's just too much fluid in the system.
Right. So, and I meant to point that out yesterday. When we're getting into heart failure, but if that heart is failing, they're gonna have signs and symptoms of heart failure. And JVD, jugular vein distension, is one symptom of right-sided heart, just heart fluid backing up. So JVD is so this is the type of question where you're reading a patient history and we're gonna say, what would you report to the doctor? Meaning you have to recognize a complication, recognize their symptoms, and then report it. So you have to take a step back and kind of look at that, understand what they came in for, understand what the complications this patient is hopefully not gonna experience, but how do you recognize that? And that's what we report to the doctor. Okay. So which laboratory assessment diagnosing the patient's MI? No, you don't wanna go home early. Alright, so here's these pictures. I recommend you printing these out while you're studying, because anything that you can visualize to show the blood flow to the heart, where is the blood backing up